I'm just going to give you a brief introduction to our program, which I know many of you know about quite well. The Caregiver Support Program of the Dementia Care Collaborative was started at Mass General in 2017. We're part of the Palliative Care and Geriatric Medicine Unit. And as many of you know, we have a terrific mission. It's to transform memory care. We exist at Mass General to educate, to connect and support. And we work with patients, family, clinicians, and the community colleagues. We offer care consultations to caregivers and patients in specific clinics, skills classes for caregivers, support groups, and health and resiliency programs. And for those of you who are on our distribution list, and actually you probably all are because you registered, you get our newsletter and all of our programs. So we hope you can come to additional programs in the future. Our program is largely funded through philanthropic support. And if you're interested in learning how to support our program, please reach out to one of our team members or even check our website. And we really hope that this monthly series is helpful to you. And as Susan said, in about 10 days, the recording of the program will be available. So you can certainly share it with your family and friends then. Thank you, Judy. And now I have the tremendous honor and pleasure to introduce Dr. Olivia Okereke. She is the Associate Professor of Psychiatry at Harvard Medical School, the Director of Geriatric Psychiatry, and the Department of Psychiatry at Mass General and Harvard Medical School. Dr. Okereke is Director, I've already said, of Geriatric Psychiatry and of the Mass General Psychiatry Center for Racial Equity and Justice in the Department of Psychiatry at Mass General Hospital. She is an Associate Professor of Psychiatry, and she's also an Associate Professor of Epidemiology at the Harvard Chan School of Public Health. Dr. Okereke is committed to research in late life mental health and well-being. Her program at Mass General has been funded by numerous awards from the National Institutes of Health, NIH, Harvard Medical School, and research foundations. She is, as Susan knows and I know, a remarkable clinician, researcher, policy person, and teacher. And we're so honored to have Dr. Okereke here tonight. One thing I'd like you to know is that she has graciously offered to have her slides sent to individuals who have registered. So rather than feeling the need to feverishly take notes, you'll get the slides within a day. And now, Dr. Okereke, welcome.
Thank you, Barbara and Susan, Chris, Judy, the whole team in this wonderful program. It's terrific to be here, and thank you everyone for attending. So I will switch now to share my screen. I'm just going to go to the right presentation. There we go. Okay. And go to full screen. There we go. So I'll be discussing evaluation and treatment of anxiety and depression for older adults with cognitive impairment or dementia. I just want to mention that I do have some support from NIH grants on this topic, as Barbara mentioned, and have published a book. So as we know, dementia has various etiologies or causes. But what's really notable is that when we look at this slide, we can see that Alzheimer's disease in particular accounts for about 2/3. There's a lot of contribution from vascular dementia, alone or in combination with Alzheimer's disease pathology, dementia with Lewy body disease also, which is related to Parkinson's disease on its own or in combination with Alzheimer's disease. And then a smaller contribution by FTD or frontotemporal dementias, it's really quite striking how much of the burden of dementia is accounted for by Alzheimer's disease specifically. And we know that the prevalence of Alzheimer's disease is increasing. Here in 2022, we're right about 6 million cases in the United States. And this graphic, which is from the Alzheimer's Association, does illustrate the trend. And part of why it looks the way it does is that increasing age is still the #1 risk factor for developing Alzheimer's disease. And so the risk increases over time as individuals get older. And because people in our country have gotten healthier and living longer, that does expose more people to the window of risks. So dementia is often referred to as major neurocognitive disorder. There's another type of cognitive disorder called mild neurocognitive disorder or mild cognitive impairment, MCI. So in this case, individuals may have more moderate cognitive decline in one or more areas of their cognition, such as memory or perhaps executive function tasks. And there is some evidence of what we call objective cognitive impairment. So it means that on some cognitive testing, paper and pencil testing, there is deficit that is sort of above and beyond anything that we would call a senior moment or normal aging. But this does not include deficits or impairments with regard to instrumental activities of daily living. So those things that interfere with functional independence, the way those things are present in dementia. It may simply mean that people have to work harder, make more compensatory strategies available, accommodate in different ways to manage these cognitive symptoms. So MCI or mild neurocognitive disorder and dementia or major neurocognitive disorder, they appear in this trajectory of progressive impairment of cognitive functioning. Now, mild cognitive impairment does not uniformly indicate that a person will progress to dementia. It's a risk state such that there's a higher risk compared to people who don't have MCI. But for those people who do progress, there's this progression from what we think of as mild symptoms to mild cognitive impairment that involves those objective deficits to major neurocognitive disorder. These are common conditions. But what we see is that it's the age structure of the population, as I mentioned earlier, that really determines a lot of how this presents itself in the US as a whole. So when we look at individuals who are in their 70s, we see that there's a pretty low prevalence overall in that age group, maybe about 5 to 6% among individuals altogether experiencing any kind of dementia. But in the older age groups, especially at 90 plus and beyond, then you have a much higher risk, a much higher prevalence rather. What's different about mild cognitive impairment is that with this form of cognitive impairment, you see a much higher percentage of individuals, maybe between 10, 15, or 20%. It varies from place to place, but on average, perhaps around 15% in the group that's in their 70s. And there's a much more gradual increase in the burden of this in the population as people get older. So that's really the big difference you'll see between the prevalence or how common MCI is compared to dementia, is what goes on in those younger age groups. But these conditions, both major and mild neurocognitive disorder, are accompanied by psychological symptoms a good portion of the time. So these have been termed BPSD or behavioral and psychological symptoms of dementia. And the International Psychiatric Association has defined these as symptoms of disturbed perception, thought content, mood, or behavior that frequently occur in patients with dementia. It turns out they often can appear for people who are experiencing even mild neurocognitive disorder or MCI, cognitive impairment. The other term you'll see for this is neuropsychiatric symptoms or NPS. You might see that term as well. So altogether, these are symptoms that affect the way people feel, think, and act, and they're related to the underlying cognitive disorder. And today, we're specifically going to focus on the ways it can affect how people feel. So as I alluded to, these BPSD or NPS, they are common in dementia and cognitive disorders. So in dementia, the prevalence on average is over 50%, onwards of upwards of 80%. But as illness progresses and people are in more advanced stages of illness, the proportion of people experiencing one or more of these symptoms is close to 100%. And as we know, they can be associated with significant morbidity, more rapid decline in people's daily functioning and their enjoyment of life, their quality of life, both for them as individuals as well as for their familial care partners and loved ones. And what is striking and notable is that there is not any specific FDA approved medication to treat these symptoms. There is no medication that has an FDA indication for treating these symptoms. We treat these both with and without medications in a way that is compatible with people's preferences and our clinical judgment. So as I alluded to earlier, the ways people feel are among those key symptoms of BPSD, specifically depression, dysphoria, and anxiety. There can be some other mood changes like irritability or mood elation or elevation, but depression and anxiety are overwhelmingly the most common of these behavioral symptoms. Although we often see quite a contribution of other symptoms you may know about, such as activities, repetitive behaviors, changes in thought like suspiciousness, or changes in sort of routine behaviors like sleep, appetite, and eating. But today we're focusing on depression and anxiety. So when it comes to the evaluation of depression and anxiety in the context of cognitive impairment and dementia, we have three key areas to focus on. Primarily, we want to understand what are potential contributing factors or precipitants. Medical precipitants can include things like side effects from medications or exacerbations of underlying conditions, maybe a lack of control or derangement in the level of control of diabetes, or perhaps there was a precipitant such as an infection or a urine infection, or a side effect or interaction with a new prescription drug. Environmental contributing factors include interpersonal dynamics. So sometimes a change in individuals a person is interacting with, or the stimulation levels that are around them, that can sometimes stir up anxiety. And then, of course, prior history. When we look at depression in particular, depression is something that can affect people across the lifespan. So any given episode of depression in a person who's over the age of 65 is much more likely to reflect a recurrence of illness from earlier in life than a true new onset of depression for the first time in later life. So prior history of anxiety and depression is very important to understanding what's going on right now. We try to develop an individualized treatment plan that will factor in all of the above and always explore behavioral interventions. First and foremost, that means everything from the kind of wonderful work that Susan and Barbara and their colleagues do around behavioral coaching and family work. And of course, looking at medication regimens, whether it's adding or reducing or modifying medications. But this always has to be done with a view toward continuous monitoring and modification of the plans, changing things so that they work, and getting to ultimately the goal, which is for people to be symptom-free, if that's possible. That's always the goal. So as I said, behavioral or non-medication interventions are always what we consider first line. That is state of the field, that is first line. We take our time with the assessment, assessing precipitants and responses to treatment. And some of these behavioral interventions, as you all well know, because you're on this call, include work with care partners and families, support, learning, education. All these kinds of things can actually bolster mood for both patients and care partners, because as we know very well, mood for patients influences the mood of care partners, and there is pretty extensive research literature on that. Other things that can help in terms of depression and anxiety include physical activity. And diversifying what is available in terms of physical activity is important. Some people like exercise, going for walks, light weights, light weight-bearing exercise. Some people like aerobics. Some people like dance or yoga. So finding physical activity that suits the individual and customizing it, that's what it's all about. But it is definitely one of those non-medication interventions that can support mood. And then some people use meditation or mindfulness, listening to music, other strategies. So these are all examples of behavioral interventions. And the goal is to either prevent the emergence of symptoms, if possible in the first place, or if not, failing that, alleviate the symptoms where we identify what those target symptoms are, be it depressed mood, be it anxious affect, worry, and distress from anxiety, with the goal of reducing both the patient and the care partner's distress, and also having downstream effects of potentially reducing the risk of additional care, premature placement into a facility or memory care unit, or hospitalization, some of which can be consequences of behavioral symptoms. So this is just a schematic. This is adapted from work by one of my wonderful colleagues, Brett Forster, but this is, I think, a very helpful schematic that illustrates how we go about this process of evaluation and treatment. We try to identify specifically what are the target symptoms. Is it feeling sad? Is it lack of interest? Is it worry, panic, fearfulness, whatever it is? And then evaluate what are the medical precipitants, what are the psychiatric potentially precipitants or history that is relevant, and then treating to the target while evaluating the environment, making modifications in those non-pharmacologic areas, and in conjunction with pharmacologic areas if necessary to achieve the goal, which is symptom relief. And this process is iterative and needs to be revised in real time as needed to treat to the target and achieve symptom relief. That's always our goal. So first I'll talk about depression. So as some of you may know, there's a form of depression we think of as clinical depression. We call that major depression. And it has a very strict definition, which appears in the American Psychiatric Association Diagnostic Manual. And it involves experiencing one or perhaps both of two core symptoms: depressed mood or sadness, most of the time, nearly every day, or a pervasive lack of enjoyment. We call this anhedonia, not wanting to do anything, not being interested in anything, things not bringing any pleasure. So those are the core features. And then there are these other symptoms of sleep disturbance, feelings of guilt, lack of energy, poor concentration, changes in appetite, be it increased or decreased, changes in sort of motor behavior, be it increased or decreased, and in some severe cases, suicidal thoughts or behaviors. These are the supporting symptoms behind these two core features. A person who experiences this, at least 5 of these 9 symptoms, where at least one of them has to be either the sadness or anhedonia for a period of 2 weeks or longer, most of the time, nearly every day, is experiencing an episode of major depression. But it turns out that what is far more common is what we call minor depression or subclinical depression in older adults. So for example, if you took a slice of the population, of the community at any given time, at any given point in time, maybe about 2 or 3% of older adults might be experiencing a major depression. But at least 10%, or perhaps north of that, closer to 12%, would be experiencing some degree of minor depression. So what that means is a person may not be experiencing the full complement of major depression, but they might have lack of enjoyment, problems with their sleep, and a real lack of energy. Or they might have sadness, a loss of their appetite, and inability to concentrate. But they don't have any of the others. And so this means that they wouldn't meet those full criteria, but they're not exactly asymptomatic. They are experiencing something that is clinically relevant, and we call this minor depression. So the prevalence of either major or minor depression in Alzheimer's disease, again, is very high. So estimates range from 30 to 50%, but much more of this is what we would consider minor depression. So symptoms of depressive symptoms that wouldn't meet those full rank criteria for major depression. And it's important to note that depression and cognitive impairment and dementia is not solely determined by awareness of dementia, or a reactive process in which perhaps people's awareness of the symptoms leads to a reactive depression. It's not really what we find is primarily the case. We are learning that there are biological changes in the brain that are related to cognitive disorders that really are predisposing people to experience this. Specifically, there are neurons or brain cells that are lost in certain locations, strategic locations in the brain, that reduce the levels of chemicals like norepinephrine, which is noradrenaline, or serotonin. And this feeds into this increased susceptibility. And there are other mechanisms that are being researched that we're learning about. But one of the interesting things, of course, in this issue is that, as I'm sure many people in this call have experienced, it can sometimes be difficult to parse depression as a symptom in cognitive impairment and dementia from the underlying symptoms of Alzheimer's disease or dementia itself. And so there's been some work to try to differentiate what kinds of clues or features might tip us off that this is primarily a depression versus something that is related to a symptom expression of the cognitive disorder. So, for example, as I alluded to earlier, with depression, some prior history of depression at some time in life is more common than with Alzheimer's disease. There is a duration of symptoms of the cognitive impairment is much more likely to be short term if it's caused by depression as opposed to Alzheimer's disease, where the symptoms of cognitive impairment are more of long standing. The memory complaints are often more frequent in depression because there's more of an insight or recognition of the impairments at that stage. Another thing that might be seen is that the cognitive impairments associated with depression are what we call effort dependent. So it means if people get encouragement, they kind of get some support or encouraged through trying to do some of those cognitive tasks, they can do a little bit better. But in the case of cognitive impairment related to Alzheimer's disease, people are really trying, but because of the cognitive disorder, it can often be difficult. So the effort is really good. Prompting helps in the case of cognitive impairments related to depression, less so for Alzheimer's disease. And similarly, in depression, even though people may say they don't remember things, they're having more difficulty cognitively, if you provide a prompt or a cue, they may be able to say, oh yeah, okay, I remember, it's that. Whereas in the case of Alzheimer's disease, it's an amnestic process. So the information kind of gets lost. And so trying to cue people with recognition memory doesn't really work as well. One important question, though, in this whole space is whether or not depression, in some cases, can really be an early manifestation or a harbinger of what may later develop into a cognitive disorder. That is at the tip of an iceberg? This is a really fascinating question. It's an intense area of research. And so specifically what people are probing is the possibility that later life onset, so especially people who are experiencing sort of a surge of depression and anxiety for the first time in their lives, in later life, where they didn't have this earlier in their life, whether this emergence of later life neuropsychiatric symptoms or behavioral symptoms, depression, anxiety, and so forth, may represent a risk state for cognitive decline, for future cognitive decline or risk of dementia, whether it could possibly represent a prodrome or early manifestation. So there's ongoing work in terms of whether these symptoms may be an early indicator of risk for cognitive decline, and if so, specifically, what kind of symptoms may be risk indicators. So we'll have to stay tuned on that. But it just kind of speaks to the complexity of the potential nexus around depression and cognitive disorders. But getting back to the treatment side, when it comes to depressive symptoms and cognitive impairment and dementia, as I said, first line is behavioral. Non-medication solutions include things like health and lifestyle interventions. And some of that involves addressing the precipitants that can keep people in a sort of spiral of depression and anxiety. And these things include pain. So addressing bodily pain, the sources of pain, whether it's through therapy or meds, physical therapy or medications. Addressing pain is important. Sleep and keeping a good sleep schedule, healthy diet, particularly the Mediterranean diet is one that seems to have all of the components that's related to being both benefit potentially to mood and cognition, and exercise, as we see here. Perhaps exercise more than any of these interventions has the most robust literature in terms of its benefits with regard to depression. But there are some other types of non-medication treatments that involve sort of exercise programs. So this was a randomized trial that developed an exercise program featuring patient and care partner dyads versus just the usual care. And they found that the people who were enrolled in the exercise program at 3 months, so it's short term, they had better physical functioning. And over the long run, over 2 years, they had better physical functioning and a trend toward being less likely to go early into placement in memory care related to behavioral problems. And depression improved, and the improvement was sustained over 2 years of follow-up. There's some other non-medication treatments worth noting. So psychotherapies, cognitive behavioral therapy, interpersonal therapy, and problem-solving therapy. These are all evidence-based and indicated for the treatment of depression in later life. One of the challenges, however, can be that sometimes, because especially in the case of CBT, these are learning therapies, doing the therapy itself can be challenged by the presence of cognitive impairment. So there are some adaptations. For example, problem-solving therapy has some adaptations that make it work a little bit better for people who are coping with cognitive impairment. In severe cases of depression or treatment-resistant depression, other strategies include such as ECT, which is electroconvulsive therapy, or RTMS, which is a newer, and there's some emerging treatments called transcranial magnetic stimulation. But again, these are often in cases where people have not been able to respond to either therapies, behavioral interventions, or medications. So less commonly required. But as I mentioned, the psychotherapies can be adapted to some of the sensory, cognitive, and physical impairment challenges for people who are experiencing cognitive disorders, such as more frequent sessions or more time per sessions, introduction of cues and use of reviews in administering the therapy. People kind of need to get socialized to the process and definitely allowed to engage in sort of the core elements of the therapy and not sort of fall back on just reminiscence or just focusing on daily physical impairments or challenges, really engaging in the therapy. But to the extent that people do engage in the therapy, can derive just as much benefit as older adults without cognitive impairment. There's less known about how some of the therapy modules work for people who are coming from different cultural backgrounds. There's a lot of work in this space with regard to also peer counseling as a mode of delivering this kind of treatment to address depressive symptoms. But now I'm going to shift to talking about medication, since that's a lot of what people do undertake, and I know what many people may be interested in. So I'll sort of overview first. We have a rational approach to medications in this context. We want to ensure a careful diagnosis. We want to address the needs for the careful medical evaluation, reviewing all medications, not just prescriptions, but also over-the-counter medications that can sometimes exacerbate symptoms. There are some classes of drugs that can depress mood, certain antihypertensive medications, for example. And so something as simple as removing a medication that is associated with depressed mood, and changing it to a different antihypertensive can be a strategy. We always operate with a view toward reducing drug-drug interactions, minimizing what we call polypharmacy, which is that stacking up of an increasingly long list of medications. And then in introducing any medication, our goal is to start at a low dose and advance slowly, where we allow for a full therapeutic trial. And I underscored this in particular because I can't emphasize this enough. Far too often when people try medication, they might experience some mild side effects over the first few days or so forth. They're not intolerable, but they're not entirely pleasant. And people will respond by saying, I can't take this, I have to stop the medication. And what happens is that we can lose the opportunity to see a medication that really might have helped someone if we'd stuck with it for longer. So unless the side effects are truly intolerable, it's really important to treat for a full therapeutic trial, target symptom focus, so that we know whether or not this medication has worked or it didn't. And if it didn't work, we can move on to the other one, not having any questions about if we have to revisit it. So certainly I put a lot of time into education and planning, thinking about what the symptom targets are and the duration of the trial and what side effects people can anticipate, since often those side effects will emerge early. They may abate after a period of time, and then the benefit of the treatment effect will be more apparent within a few weeks later. So some of the medication classes that are relevant are listed here, but it's really the antidepressants primarily that are used medication-wise to treat depression and anxiety. So I'll talk about the antidepressants. So as Barbara mentioned, you won't have to furiously write down the content of the slide. And it's not it's not my intention that you learn the dosing of these medications. The value of this slide is that you can see the names of the medications. You can see what classes they belong to, why certain ones are used, why they aren't used, what kinds of side effects are common to them. That first class of tricyclic antidepressants is not commonly used in older adults with cognitive impairment because a common side effect is what we call anticholinergic side effects of these drugs, which can worsen confusion. And there's some other things as well, but that's really the big one. The most commonly used treatments for depression are these selective serotonin reuptake inhibitors, or SSRIs. And you'll see fluoxetine, sertraline, citalopram, and escitalopram in particular, I think, are the most commonly used. And these are the dose ranges that are undertaken for people in the age range of most people experiencing cognitive disorders. So that just kind of gives you that familiarity. And by starting at a low dose, that low end of the range can go even lower. For example, I've started people on as low a dose as 2.5 milligrams of escitalopram, although most people would probably start at 5 milligrams. Other classes outside of the SSRIs include the serotonin norepinephrine reuptake inhibitors. So these include medications like duloxetine or venlafaxine. And many of these will be used, let's say, if the earlier trial did not succeed. Mirtazapine is a good example of an antidepressant that might be used where we can leverage a side effect for the benefit of treating someone's symptoms. So one of the more common side effects of this medication can include an increase in appetite and sometimes weight gain related to that, and sleepiness. So for people whose depressive symptoms include sleep problems, and that is a very common one, sleep disturbance or loss of appetite, we can actually leverage this potential side effect of an antidepressant to treat all of those things, improve the mood, improve the sleep, and perk up appetite. Similarly, with trazodone, it has some mild sedative properties that make it very nice for alleviating anxiety as well as sleep problems when people are experiencing depression. By contrast, bupropion has a totally different mechanism than any of those serotonin drugs, and it may be more valuable for people who have low energy, poor concentration, and need a little bit of perk up. And that is because there's this heterogeneity, this variability in the kinds of depressive symptoms that any one person has. So that's why we have to customize and individualize things. And I've listed some other drugs here, which are not first line. They're not first line and they're not classified as antidepressants in all cases here. But they're sometimes medications that we use in combination with antidepressants when we don't get a full treatment effect for managing depression or anxiety with any one drug on its own. And I've highlighted here this class of drugs called the atypical antipsychotics. And these are important. You may hear terms like risperidone, olanzapine, aripiprazole, quetiapine. These medications initially started out as antipsychotic medications for primary psychotic disorders, some 25, 30 years ago or more. But it turns out that they have a variety of other FDA-approved uses now, including a wide range of uses for treatment of mood disorders and depressions. And so these are medications sometimes that might be added to an antidepressant to boost the effect. They might treat other kinds of symptoms, behavioral symptoms outside of depression and anxiety in dementia. There are some important potential side effects, including specific side effects that are most relevant to people who are older, and safety side effects that have to be monitored. So these are not to be used lightly, but they can be used, again, not FDA approved for this, they can be used to treat some of these behavioral symptoms. Now I'll talk about anxiety. Now, first and foremost, I have to say that I have to disclose that when I hear someone say that the problem is anxiety in the context of cognitive impairment or dementia, I myself become anxious. And the reason is that anxiety is a term that can be used to describe a wide range of things. So it becomes quite a task to parse exactly what is meant by anxiety. Worry, tension. Is it panicky feeling, being fearful, afraid of something? Is it physical restlessness, fidgeting, pacing, wandering, sort of anxious physicality? Is it maybe being a little bit tense and irritable and on edge? A tendency to get a little bit aggravated or agitated? Is that the anxiety? Is that the nervous feeling? Sometimes it's an uncomfortable internal feeling, something called akathisia, which actually can happen in Parkinson's disease. Sometimes when people talk about anxiety, what they're talking about is sleeplessness or fitfulness, people getting up at night and walking around, or just not feeling right, dysphoria. So anxiety, I put in quotation marks because it can be all over the map in terms of what people mean when they say anxiety. So oftentimes it's important to go through this and try to figure out, well, what exactly is that target symptom when we talk about anxiety? What exactly are we trying to treat? And it might be any one or some combination of these things on this slide. When it comes to managing behavioral, using the behavioral management techniques or solutions, certainly there are social or routine-oriented strategies. So socialization, maintaining connections, being around familiar faces and friends can alleviate anxiety, whether it's the routines of going for walks with certain friends, certain days of the week for an amount of time, or whether it's the ritual of spending time with family members and certain activities that are calming, reassuring. These kinds of things actually can alleviate anxiety behaviorally. Especially if it's mild anxiety, situational anxiety. But medications are also used to treat this kind of anxious nervousness. Citalopram was tested in a very rigorous trial that was published in a high quality journal a few years ago. This was compared to psychosocial intervention. And what they found is that the individuals who got the medication did do better than those who didn't when you had these anxious symptoms that were on the more severe end, right? So exactly those types of symptoms that might not respond alone to the psychosocial or behavioral interventions. And they tended to reduce not only the anxious agitation, but also the distress that care partners and family members were experiencing. There's some important side effects. There's a cardiac indicator we call the QT prolongation. It has to do with a finding on the electrocardiogram. And that's something that we have to monitor for, because these medications are more likely to produce this finding, and it can predispose people to the risk of certain kinds of arrhythmias. So this is part of what is so important about the monitoring, and why individuals will get some blood tests or some EKGs periodically to monitor. But otherwise, this is a medication that was found to be generally safe, without major safety issues in general use. I wanted to make a quick word about benzodiazepines, because oftentimes when we think about anxiety, we think about anxiolytic or anti-anxiety drugs, the first thing that comes up in many people's minds are these benzodiazepines. And they include things like diazepam, clonazepam, lorazepam, and others. So generally, we don't consider these to be first line to treat anxiety anymore. It's really those SSRI type drugs. There are some other important risks that are particularly relevant to people with cognitive impairment and dementia. These drugs have been consistently associated in large studies, large epidemiologic studies, with increasing the risk of dementia in people without dementia to start with, who might just have cognitive impairment without dementia to start with, increasing their risk of dementia and worsening memory over time. They're also associated with, this is an established risk of falls and associated injuries, including fractures, developing physiologic and emotional tolerance and dependence, which can result in worsened anxiety upon discontinuing the drug. So there's some very important risks associated with these, which is why they're not considered first line. But they can be used when in low doses, or used judiciously, perhaps used in very strategic contexts to manage episodes of particularly severe symptoms where people may respond to that and nothing else. They can sometimes be used more easily in individuals with cognitive impairment and dementia who are younger, perhaps in their 50s or 60s, and less susceptible to falls. But they do need to be, they can be used, but do need to be used very carefully. And if they do need to be discontinued, it needs to be done very slowly. I wouldn't taper someone off these drugs at a pace any less than after a few months of slow tapering, sometimes cross tapering from one type of benzodiazepine to another longer acting form that makes it a little smoother or easier to come off the medication, especially if a person might have been taking it for a long time. There are other medications used to treat anxious distress or anxious behaviors related to cognitive impairment and dementia. I've listed a few here. These are all really emerging. Prazosin is a type of antihypertensive. Dextromethorphan, quinidine combination was recently approved for some other contexts, not FDA approved specifically for behavioral symptoms in dementia. Ketamine and cannabinoids are a very interesting emerging area. So dronabinol, which is a type of prescription drug that is THC equivalent, a THC-like drug, and CBD, cannabidiol, which can come in many different formulations. These are being researched in terms of their use. They don't have currently FDA approved use for this, but is something that people are actively exploring. I mentioned also ECT, that's really for very severe behaviors. It's really not at all typical that would be used to treat anxious distress behaviors. And as I alluded to before, while both benzodiazepines and atypical antipsychotics can be used, a lot of caution is required. So I wanted to just overview some general principles when it comes to these medications, because more often than not, people will be taking some medication to manage depression or anxiety from cognitive impairment and dementia. So when it comes to starting these medications, there are no bad questions. There are absolutely no bad questions. It's an opportunity oftentimes to address biases people might have about medications or preconceptions that people may have or major concerns that people need to work through to feel comfortable about starting a medication. And it's the opportunity to really identify the priorities. What is the focus? What is the target symptom that matters most to people to resolve? For these symptoms also, it's important to do readbacks of instructions. So insist on that, sort of, read back what you think you heard the doctor say, or get it printed out or written out. Including more family members wherever possible is better than fewer, because you have multiple people sort of hearing the message and kind of keep things consistent with each other. And then always keeping a medication list on one's person at all times. Using pill organizers and med minders can be very, very useful because, again, as the number of medications get introduced and increase, that can be more confusing to keep track of. Some other important principles, pharmacodynamics. This refers to how medications affect the body. And in aging, there are a variety of things that change as it pertains to how medications affect the body. So there are changes in the ability of the brain to modulate the receptors that are where these drugs attach and produce their effect. There are also changes in the activity of enzymes that are used to process some medications. And this underlies some of the sensitivity to certain drugs, in particular, the sensitivity older people have to those anticholinergic drugs. So this means that older people with cognitive impairment and dementia, they might be predisposed to higher risk of certain drug-drug interactions related to being on polypharmacy, multiple drugs that are affecting the same neurotransmitters or brain receptors. On the flip side, you also have pharmacokinetics. This refers to how a body affects the drugs. So bodies affect the drugs through how the drugs are absorbed, how they're metabolized by our bodies, how they're processed and eliminated by our bodies. And so this also changes with aging and underlies why dosing a medication once a day often is so much easier to tolerate. It's almost sometimes not as easy to tolerate, rather. So what can happen is that there will be higher peak values. So the peak level that's in the body after a single dose may be higher with a single daily dosing. And that is typically the phenomenon that's associated with the side effect. So splitting the dose might reduce the side effects that are experiencing. So it's the same total daily dose, but now the dose is split in two. But this has to be weighed against a different problem, which is that having two doses to take of a drug per day as opposed to one can increase the likelihood that any one dose may be forgotten or there's some adherence issues. So these things have to be balanced. Also, the side effects, if they're gastrointestinal in nature or if people have sedation, sleepiness, dizziness, this would argue for giving the medication at bedtime. So oftentimes people will ask me, should I take this medicine first thing in the morning or at night? And the reason that question isn't always the same answer is that so much of this depends on the specific drug, whether it would be once a day or twice a day, whether it would be best taken in the morning or in the evening. And if the person has had side effects, that then might argue it's better to take it in the evening instead of the morning. Or if a drug is activating, it might be better to take in the morning. Some people respond to a drug, the same drug may be responded to by one person differently than another. So that one person might get sedated and take it at night. Another person might find it activating and it's better to take it in the morning. And that's why these questions don't always necessarily have a one size fits all answer. And then if people have certain symptoms like tremor, again, shakiness, this is another one of those symptoms that might indicate peak effects. And so splitting the dose might be better. So the other thing I wanted to point out is what's called the Beers criteria. So it's good to know about the Beers criteria. So this was established many, many years ago. It is updated and published regularly by the American Geriatric Society. And basically it's kind of a bad guy list. It's sort of a villain list in terms of medications that could potentially cause problems for older adults. Now, many of these medications are ones that can be used and should be used depending on the indication clinically. It's simply a list that alerts people to those medications that have a much higher likelihood than others of causing problems. So for example, anticholinergic medications like diphenhydramine, or antihistamines, these medications that are used for allergy and those types of symptoms, are notorious for anticholinergic side effects and can really severely exacerbate or cause serious episodes of confusion for people with underlying cognitive disorders. So unless there is just some dramatic reason, like a person is having a serious allergic reaction and immediately needs diphenhydramine, I can't imagine any situation in which that would be appropriate to use. Paroxetine is a type of antidepressant, but it is weakly anticholinergic. Because there are so many other SSRI antidepressants that are available, again, I don't see any reason to choose this one for someone who has a cognitive impairment and dementia. So the list, the Beers criteria list also includes the benzodiazepines, those Z drugs, because they are very sedating. They can, especially for people who are older, maybe in their 80s and beyond, at higher risk of falls in the context of cognitive disorders, those are best avoided. Certain muscle relaxants for the same reason, as well as their anticholinergic effects in some cases. Some of the drugs on this list aren't necessarily like bad guys with regard to brain effects. So the NSAIDs, or non-steroidal anti-inflammatory drugs, you might see listed like ibuprofen, naproxen sodium, and it's not because of brain effects. It just has to do with the fact that caution is needed around potential interactions. So some people, particularly if they're on blood thinners, may be at an exacerbated risk of having gastrointestinal bleeding if now those drugs are then combined with those SSRI serotonin drugs. So it's just kind of a word of caution more than anything. And then it's also generally advocated that we should avoid people taking 3 or more of any of these central nervous system or CNS active drugs whenever possible. So that means, for example, if a person is already on an antidepressant, maybe now they're getting an augmentation with one of those second generation atypical antipsychotics, or maybe some other drugs. It's not a great idea for that person to be using opioid pain medication or some other third psychoactive drug, because as these things compound, there's that increased risk for falls. This can be very, very challenging to manage. Sometimes the secret recipe for any given person to manage their depression and anxiety and feel well and feel good again involves there's three drugs or more. This is just kind of a general point. It's not one size fits all, but general guidance. So just to summarize those key points when it comes to the medications we use to treat depression and anxiety in this context, starting low, very low sometimes, and going very slow. So you might get instructions to change the dose, maybe every week. In some cases, every 2 weeks, that slow, but not to just ramp up quickly, because that's when people can kind of get bombed with side effects when that's done. Making one change at a time, this is a critical principle, and it's related to the whole idea of the adequate therapeutic trial. If we change more than one drug at a time, then let's say people get better. Well, we won't really know which drug did what. And that's a recipe for people ending up with a lot of medications, because people get nervous about getting rid of one of them because they don't know, maybe that was the one that helped. And by the same token, when people start 2 drugs at a time and there's a bad side effect, you might lose out on a good medication because it got blamed for the bad side effect that was actually only related to one of them, but you can't parse which one did which. So continuous need for reevaluating each drug at each visit. This is also really important. You can kind of alleviate that problem of people ending up on too many medications when they have the opportunity to review, do they need to be on something or not? And it's always also an opportunity to screen for drug-drug interactions, because people start new medications all the time for other medical conditions. As those other medications get added, someone like myself will monitor, well, do changes need to be made in the treatment for depression and anxiety because of a different drug that was added for hypertension or diabetes or something else? A simple regimen of once a day is optimal if it's possible, because this allows for reducing the burden of pill taking. I tend to also advocate, and perhaps you could ask for this if this isn't raised, is dose strengths that reduce the burden of pill taking in terms of the size of the pill. Some pills are just easier to take or easier to cut, and this makes a difference. Medications that can be offered in liquid formulations or sprinkles or capsules that can be emptied into some food, if swallowing is a problem. And that can definitely be a problem in certain dementia disorders, is worth noting as well. So just to review, again, this is our comprehensive framework. Think about whatever the target symptom is. If it's depressed mood, if it's lack of interest, the anhedonia, or if it's anxiety, what does that mean? Is it restlessness? Is it related to worry or tension or fear? Evaluating precipitants thoroughly, medical and psychiatric, and then treating to the target. Employing both environmental, non-pharmacologic behavioral, as well as pharmacologic interventions with the goal of relieving the symptoms. So I'll stop there. Thank you for listening. I wanted to make sure we leave plenty of time for questions, and I do think that we will have plenty of time. So I'll stop the share.
Thank you. Fantastic. Thank you so much, Dr. Okereke, and we do have some questions to begin with, and it's a very important theme. Would you recommend working with the primary care doctor or neurologist on prescriptions? We've been doing a little of both. My mom's anxiety is increasing, and it's a discussion we wanted to address in addition to her Alzheimer's. The same woman added 2 other comments. We're more focused on her anxiety at this point. And then she also said, I should also state that she is currently on medication for anxiety. But I think, and just to follow up, because another person added, my husband's neurologist and primary care doctors work together on his medicines. So that whole theme of where do I turn?
Yeah, that's a great one. So in general, I tend to work more closely with a primary care physician. And that's because of some of those issues we alluded to earlier, that understanding the overall medical context of all those other medications that a person might need to be taking, whether it's, they're on a blood thinner for their atrial fibrillation, they're on diabetes medications, they're on the antihypertensive, and so on and so forth. So having a language to know, what I can do might impact all those other aspects of care. Is really what we depend on a primary care physician or a geriatrician. Sometimes the geriatrician is the primary care doctor to help with. So where I'll more commonly confer with a neurologist is around if there are changes that we're thinking are sort of part of the progression of the underlying dementia. So for example, very often I might be more likely to confer with a neurologist if there's a decision about, okay, is it time to add memantine? Or is it time to maybe dump the donepezil? We've kind of gotten as much out of it as we can, and maybe it should be memantine only. Or sometimes it might be an instance in which it seems that the anxiety and irritability, the sort of restlessness has to do with sort of a general sense of unease. It's not really specific to, say, major depression or panic disorder or specific psychiatric disorder. And I might have the impression that if the neurologist introduces a new dementia medicine like memantine, maybe it might sort of, as an umbrella, help with that symptom. That's more the context in which I would be working, psychiatrists and neurologists in close concert around behavioral symptoms. In general, if someone's been referred to my care or my colleagues' care in geriatric psychiatry to manage these symptoms, we're going to be much more likely to be interfacing with the primary care doctor because of the complexities.
If I can follow up on that, Dr. Okereke, for the patient who perhaps does not have a geriatric psychiatrist, but has both a primary care doctor and neurologist. Right. I think the question I often hear is, so if I'm thinking that perhaps this is depression, where's my first call as the care partner? I mean, when there isn't a geriatric psychiatrist, is it the neurologist, or do I start always with the internist?
I would reach out to the internist. There are, certainly within the context of Mass General, we have a lot more resources than oftentimes people might be experiencing elsewhere, sort of outside of greater sort of Metro Boston, elsewhere in the state or around New England or elsewhere in the country. There's certainly a lower density of geriatric psychiatrists, but there are consultations sometimes that can be worked out. Sometimes even electronic consultations, so sort of one-time consultations that can be worked out. So I think it's a good idea to reach out to the primary care physician just about, saying, depression is the concern here. Anxiety is the concern here. I'm really concerned about making sure that we treat that and making that clear. So I think that might be a path to get referred to someone who's a specialist in this area, such as geriatric psychiatry. There are many neurologists who are very capable with managing behavioral symptoms, but as I described, the way we've kind of marched through this as a psychiatrist is quite a bit different. And so if you try a few things and maybe they work, then great. But if they don't, then it's a good possibility that it may not be enough only to work with the neurologist. And that's where a psychiatrist's input can be helpful. Again, it may not be possible there may not be the availability of a psychiatrist to follow people repeatedly over time, the way that I do in clinic or some of my colleagues do in clinic. But even a consultation can be incredibly useful.
That's great. And an important question is, once an Alzheimer patient begins treatment pharmacologically for depression or anxiety, how long will they need to be on those medications? It's a great question.
That's a great question. So I should back up by saying that the way that we approach this, the treatment duration or sort of estimated treatment duration looks very different when we're managing sort of, let's say, mild depressive symptoms or anxiety symptoms in the context of cognitive impairment and dementia versus, let's say, someone who had a major depression with or without underlying dementia or cognitive impairment. When a person has a major depression, there are kind of some general rules that tend to be followed here. So the objective is always to treat to what we call a symptom remission. So we're looking to see that the treatment was effective in remitting the symptoms of depression so that those target symptoms that were bothersome have been eliminated and now the person is symptom-free. So then there may be a period of up to 2 years when a person may stay on the medication, because that would limit their risk of what we call a symptom relapse, which is now you're better, you come off the medication and boom, the symptoms relapse. So sort of buffering people against that is why you might see that 2-year period. Also, 2 years is the benchmark when we know that a person has had a true long-term remission. of symptoms.
Yeah.
And so I'll tell people, you know what, after that, you're kind of done. And, if you want to come off the medication, we can taper you off of it. You probably will be okay. In the context of cognitive impairment, it's a little bit different. So those symptoms don't really have those 2-year benchmark rules of major depression. And we really are treating symptoms by target. And the thing to keep in mind is the reason you can't answer, well, how long is it going to be on this drug? Because the symptoms evolve over time. The behavioral symptoms of cognitive impairment and dementia are actually evolving. So it may start with depression and anxiety, but then there may be other behaviors or other issues that emerge over time: irritability, restlessness, sleep changes. So it's a moving target. So we have to sort of identify the correct target and then treat and resolve that as best we can, and then observe to see if there's a cooling off or if something else emerges that we have to sort of, go after. So that can often change things. Maybe a person started an SSRI for depression and sleep disturbance, and then they're well, but then there's some anxiety or there's something else. And so maybe we might keep them longer on that medication, even though the depression has resolved. So that has a lot to do with it as well.
Absolutely. And there's an important question about Alzheimer's drugs. How do you know when it's time to potentially stop the Alzheimer drug and decide that they're no longer working? You're smiling because that's a big question.
That's a big question. So when the original clinical trials for the medications like donepezil came about, they identified that, first and foremost, as we know, they do not cure the dementia, but they can reduce the rate of decline, reduce the pace of decline. But it also appears to be that there's kind of a window of benefit on average, where for most people, it somewhere hovers around 18 months, but people vary. So that window could extend to 36 months, 3 years, or beyond. But there definitely does seem to approach a time when people are really not doing as well. And it seems that the benefit is exhausted. And so even though the combination of those donepezil, memantine, that combination of drugs is definitely favored and is FDA approved for, moderate stage Alzheimer's disease, moderate severe stage Alzheimer's disease, and all that's well and good. One of the things we'll factor in is if the person has been on, let's say, donepezil for a very, very long time, and there's progressive memory loss and change in cognitive symptoms, we really don't think they're deriving any benefit. We have to make a sort of risk-benefit calculation. People may be on, let's say, a beta blocker for hypertension or heart disease, right? That is an interaction with one of those drugs like donepezil that may really reduce a person's heart rate. There may be some safety issues with that. If we're worried about that person having a fall or having some issues related to a slow heart rate, now it doesn't really seem like it's worth it as much to be holding on a drug that we don't think may be totally helping. Or maybe another drug is needed to be introduced and has a potential interaction with something that we're, again, not totally convinced is still helping. That's an example of where someone might come off of that donepezil, they stay on the memantine moving forward. There's been a lot of discussion about this, and if people come off of donepezil, how slowly do they need to come off of it? Because there have been plenty of reports and examples of people having a little bit of a sort of a rebound of confusion when they come off too quickly. And certainly that's a drug that we start slowly, very slowly. I take about 2 months at least to get people up to their target dose on donepezil. So if it started slowly, it should be stopped slowly. But yeah, so those are some of the issues that pertain to that question of coming off an Alzheimer drug.
I just have a quick follow-up. I think sometimes some of us have heard that coming off an Alzheimer's drug, even outside of the arena of decline, will cause a regression. Like whatever we've gained, we lose. If it's my mother's clarity of speaking, is that rumor, or does that do you sometimes see that?
No, Yeah, I mean that's what's kind of being investigated a little bit to try to get some clarity around that, because that's not definitely uniformly the case or hugely common, but it's one of those things where there's enough cases of that, there's enough reports of that definitely it's a concern, and I typically there haven't been any cases unless there's been some huge issue of safety where I've completely withdrawn memantine altogether. In some cases I might lower the dose. I might lower the dose by 50%. There's other ways of handling it. But yeah, that is definitely something that is a concern. And so for that reason, it's part of why people may stay on that donepezil and memantine combination for a very long time and just kind of, if it ain't broke, don't fix it, kind of like leave it going because of the concern about the regression. But I think that's less of a concern if a person, let's say if they've been on it for like 5 years, if they've gotten what they're going to get out of it. And if there's side effects, especially drug-drug interactions, because the drug class of donepezil does have some very important side effects related to the heart and heart rate. And older people are often on medications that also affect heart rate. And this is something where I've seen people literally end up in the hospital with dangerously slow heart rates or getting dizzy and falling. I mean, there's some really potential serious side effects in certain combinations. And so if it's really a question of deciding between, does this person stay on their beta blocker or get rid of the donepezil that's not helping them anymore? Well, I don't think there's much question about which one I would drop first.
Great, thank you. A question from someone who I think might well be a professional clinician is, sometimes I try to take, I think so, meds away from a patient and working with a primary, and they tell me no, because when the side effects entail. And I asked for a little bit more information. She said, like if a patient takes 12 medications, one is magnesium and another one Claritin. So does that make sense to you? This is a clinician who's trying to do the work, but
yeah,
there's resistance.
Oh, that's a wonderful question. So this is a term we call deprescribing. And it's one of the hardest things to do. So my admiration to the clinician who's describing this, it's one of the toughest things to do, because often someone, for example, I might see someone for the first time when they're on 12 or 14 medications. I don't know, do they need to be on that many? I don't know which one of those medications might be causing some side effects or causing some problems, complicating the attempt to treat their depression or anxiety or behavioral symptoms. It gets really, really tricky. And so going through that list and prioritizing, okay, what can we let go of? And doing it one by one, because you can only make one change at a time, is time consuming, it's lengthy, but it can be done. It absolutely can be done. It's just systematically marching through it. And, I appreciate, what this clinician is saying about the effort of doing this and sometimes the pushback and resistance. But, I try to, talk with family members and patients about it's really worth it, because if we can one by one sort of get rid of things that we don't need and we get a nice clean regimen, fewer drugs means fewer side effects, fewer interactions, fewer unpredictable things that we don't know. It's just cleaner, and it's always worth trying.
That's great. Before I get to another question, two other questions, there is a message of gratitude to you for your explanation about taking someone off the Alzheimer's drug. This woman says, my mom's at mid-stage and we've discussed taking her off the Alzheimer drugs at this point, as we're not thinking we've seen benefit, but we're afraid she may just get completely worse going off. She doesn't have any other medical issues other than high cholesterol.
Right.
Okay. So the next question is, what are some symptoms that indicate a patient has progressed from mild to moderate dementia?
Oh, yeah. Yeah. So there are there are different types of stages that are used. The stages of dementia that I tend to use is named after Barry Reesberg, a geriatric psychiatrist. The Reesberg stages, there's 7 stages. Basically, from the mild to moderate, what will change is that, so we sort of go domain by domain. The rapid forgetting will be much more prominent. So rather than sort of generally having difficulty remembering things, it might be something like, forgetting something literally within that a minute or two. It's much more striking how rapid the forgetting is. Definitely when it comes to behavioral symptoms, the prevalence increases. So with mild dementia, it may just be maybe some irritability, depressive symptoms, anxiety. But one of those things that may sort of jump out with a moderate stage is that more intense, agitated symptoms or pacing or fidgeting may become more prominent. And in terms of the other sort of non-memory related impairments, so we think about language, we think about something we call praxis, the ability to sort of do things. So as people go from mild to moderate stage, you may see something called apraxia, which means the person can't really quite figure out how to do something physically, manually, as well as they used to, like tying shoelaces or doing complex manual tasks. Apraxia may become more common. Aphasia, so in mild stages of dementia, really, even though there's memory impairment, the fluency of communication is kind of what it was. It's really not necessarily dramatically different, but as people move from moderate to a moderate stage, there may be more difficulty communicating or understanding what other people have been saying. So you have all these different kinds of types of benchmark, be it memory, motor, language, right? So those are the things that we're looking at when we say this is mild versus this is moderate.
And we have a final 2 questions. I think the very last one, which is wonderful, will end on research, but just as an extension of what you're just talking about now, and we'll end at 6:55, Dr. Okereke. Can you provide the symptoms going from moderate to end stage?
Gotcha. Okay. Yeah. So some of the symptoms that it looks like progression, right? So when I talked about language, rather than more prominent difficulty communicating fluently, there may be dropping out of language. So people become much quieter, in advanced stages altogether, not speaking at all, not really verbalizing things to communicate. In terms of memory, it becomes really difficult even to assess memory because of the language and communication issues. In terms of physical changes, so where motor changes in the moderate stage might have been, people doing things, but maybe not doing them quite as skillfully, right? There's apraxia. But in advanced stages, you'll see motor changes like development of rigidity, stiffness. There might even be development of some muscle contracture. It's just really difficult for people to kind of do things manually. There might be some changes in swallowing. Just like the mechanics of doing things can affect how well people do things, to the point where there can be some challenges with swallowing. And that's why we really have to be very vigilant about aspiration or choking, and modifying what people eat, soft foods or cutting up foods, to sort of mitigate that. And then some really advanced symptoms will be things like development of seizures. They could be mild, they could be brief seizures that are basically like absence seizures, or really hard to even detect. That can happen, as well as for people who are losing their mobility, it gets harder and harder to prevent some challenges related to that, such as, not ambulating or developing sores or sort of compression related sores because of sitting all the time. And that's something that people have to be so hugely vigilant around, preventing that from occurring, because people have lost their mobility and they're no longer walking. So those are the kinds of things that are advanced stage.
Thank you. And Dr.
Or
Okereke,
end
we have
stage, I think that was the question, yeah.
right. We have a final terrific question. What are the new developments that may move us beyond the current portfolio of medications? Where is the research heading? Thank you.
Yeah.
And that is
So
our
in
final
terms,
question.
sure. So there's new developments in terms of general treatment for, Alzheimer dementia. There was just the Alzheimer's Association International Conference meeting, which was just held just a week ago, actually, ended a week ago. And this is always a sort of a hot area. I think there's been some disappointment around what the drugs that were these infusion drugs that were these, what we call the anti-amyloid drugs, people might have heard about. They turned out not to particularly work hugely well, and also tremendously expensive. So unfortunately, where they are right now is that Medicare, which sort of did a whole study of this, has sort of parked them within sort of research use only. Okay. And so what's on the pipeline is more people are sort of looking into drugs that both relate to amyloid and also other mechanisms of the disease besides amyloid. As it pertains to behavior, look out for CBD, cannabinoid drugs. There's a lot of research, including some of our friends, some of our investigators and colleagues here, a lot of research going on in terms of CBD and cannabinoid drugs on behavioral symptoms in dementia and Alzheimer's disease. So really look out for that.
Okay.
And then, so I should put a last plug toward the behavioral. One of my colleagues also, who's out at McLean Hospital, has been looking at other ways, relational ways of addressing behavioral symptoms. So he has a sort of model that sometimes behavioral symptoms emerge in the context of unmet needs. And what this has to do with is the fact that people's preferences of living, of how they want to do things day to day, everything from what time they get up to what food they eat and what kind of takeout they like or whatever, that is not being met. Or maybe sort of finding ways to sort of bring people into harmony and alignment in terms of what the patient with dementia or cognitive impairment is looking for in terms of their everyday living preferences and what they're being provided as a way to prevent or reduce the level of behavioral symptoms. That's something that he's gotten funded for actively researching, including from the Alzheimer's Association and other groups. So I think there's both sort of behavioral and medication things that are exciting in this space.
We have lots of thank yous. We have an amen to a thank you. But I also just want to, on behalf of our program, the Dementia Caregiver Support Program, we are so honored that you accept our invitation every year, because every year we all benefit from you and learn from you. And throughout your talk, even to your final comment about the research your friend is doing, your colleague is doing on individual preferences, what's so magnificent about much of your approach as a wonderful physician is every individual is indeed unique, and an individual's certain physiology, of course, responds to medicine, but also lifestyle preferences, which you emphasize tonight. Thank you so very, very, very much. There are lots and lots and lots of thank yous, and you'll all get the slides. Thank you, Dr. Okereke, and have a great night, everyone.
You too.
Bye-bye.
Thanks, everyone.
Thank
Bye.
you. Bye-bye.